Hello, good morning, good afternoon, good evening. Welcome to Meet Menaca. Hope you all had a great holiday. At least in the UK, we had a bank holiday last weekend. Today, we are going to be speaking about bone health and osteoporosis with Dr. Jeffrey Jaya. He's all the way from Malaysia. I can't wait to listen to him. So today is our episode 55. A very warm welcome to you, Dr. Jeffrey.
Thank you.
Dr. Jeffrey Jaya is a consultant orthopedic and arthroplasty surgeon, hip and knee joint reconstruction unit, currently practicing in Kuala Lumpur General Hospital, the biggest government hospital in Malaysia. Graduated from Menaca Medical College in 2004, in further completed masters in orthopedic surgery in 2014. His experience in managing major orthopedic trauma and degenerative hip and knee conditions requiring hip and knee replacement surgeries for the last 7 years. Completed fellowship in arthroplasty, that is partial knee replacement, total knee replacement, and total hip replacement procedures, including robotic surgery and in Brisbane, Australia in 1920. His keen interest in robotic surgery as a frontier in future of joint replacement surgery in Malaysia. His hobbies include running, listening to music, holidaying, and hanging out with friends. He's happily married with 2 kids. A very warm welcome to you.
Thank you for the warm.
I have another common thing with you because I think we didn't qualify very far from each other, from the same state in India. So, we have a common thread. Osteoporosis is very common, as you know. Yes. You are the expert, so I better not say much about this. So how common is it and what is osteoporosis for people who really don't know much about it?
Okay, so when we talk about osteoporosis, it's basically, to put it in simple terms, the bone basically becomes more porous. So it becomes more like a sponge, So it becomes softer, so there's reduced bone mineral density, all right? So basically, as you age, the bone density reduces. So it gives rise to easier to have fractures. So we call it fragility fractures, right? So the elderly may have it, but there are certain other conditions which may predispose to it. Certain medications like steroids, and also in early menopause or in post-menopausal women. Yeah.
Sure.
Right.
And how common is that, Dr. Jaya?
Okay, so osteoporosis is quite common, especially now with the increasing aging population, right? So with advancement in medical care and increased in the geriatric population age group, the osteoporosis is more common now. It is more common in the Caucasians as compared to Southeast Asians, but now there are increased prevalence in Southeast Asia as increase in medical advancement and increase geriatric age group. Yep.
Sure. Thank you.
Yeah.
So, we hear about osteoporosis a lot, at least definitely in the parts where we live. And I know, I know people in the family also have osteoporosis, which is was not very well known as we grew up. So how can we prevent osteoporosis? I know I have, broadly, I know that we have to perhaps do some exercise or, certain dietary requirements, but how can we prevent osteoporosis together?
Okay, so osteoporosis, number one, first of all, you see the bone is a structure whereby the more we load it, the more stronger it gets. What do I mean by loading? Which means you have to exercise, you have to take care of your musculoskeletal system, which means the muscles and the bones. So if we do not walk, we do not exercise, we lead a very sedentary lifestyle, then the bone health further deteriorates. We call it disuse osteopenia or osteoporosis. It can lead to osteoporosis. So when you do not load your bone, you end up with very soft bones later in life. Another thing is to maintain a good diet. So a diet rich in calcium and vitamin D is absolutely essential to maintain a good bone health. What kind of foods are rich in calcium? Of course, as we all know, dairy products, milk, yogurt, all right, cheese, those kind of things. Of course, green vegetables, and of course, vitamin D. We are talking about fish like salmon and certain kind of fish and all that. So actually, if you just Google, there's a whole lot list of foods which are rich in calcium and vitamin D. So exercise, low impact exercise, especially for elderly, is very important. Low impact aerobic exercises, walking, tai chi, swimming, those kind of things. When you load your bone, it is good for the bone health to prevent osteoporosis. I have a lot of patients who come, after a fracture when they are old, and then they say, "Doctor, can you give me calcium? Can you give me vitamin D?" And then I want to make my bones stronger. But you need to understand, at an old age, when you pump yourself with so much of calcium and vitamin D, it's not going to make your bones suddenly strong. Okay, this is something which needs to be practiced from a young age. So those of you who have grandchildren or maybe children, from a young age, if you practice high calcium, vitamin D rich foods, then you actually maintain and preserve your bone for the older age so that you do not develop osteoporosis and eventually end up with a fracture. Yeah.
Sure. Thank you so much for that, because I think it is becoming more and more common for us to hear about vitamin D deficiency in particular in South Asians, at least even people who are abroad. Like, and definitely I know I have family in Canada and in the UK, and we hear very often a lot of people have been diagnosed with vitamin deficiency recently. So what is the recommended daily calcium or vitamin D intake, Dr. Jeffrey?
Okay, so, all right. One more thing I forgot to mention, exposure to sunlight is extremely important as well. 90% of our vitamin D comes from sunlight, all right? The rest is from dietary and other sources. So in countries which you hardly get sunlight, example, Canada, my wife is from Canada, so I have to say. So anyway, so if you have lesser exposure to sunlight, probably you have to compensate by taking supplements or vitamin D rich foods, all right? So other than that, when you talk about calcium requirement, okay, so the general FDA requirement, or even in all the national guidelines in UK or Australia or Malaysia or Asia, most of the countries, the general requirement is 700 to 1200 milligram of calcium per day. However, calcium requirement goes up in patients who are pregnant, who are breastfeeding, and postmenopausal women, all right? Of course, also when you talk about males, elderly males, when you have less testosterone, when you age, then your calcium requirements go up as well. So calcium requirement, depending on what stage you are, may go up. So when you're older, when it's postmenopausal, because of lack of estrogen and progesterone, it causes your bones to become weaker, so the calcium requirement goes up as well. All right. When it comes to vitamin D, there's a lot of material available online. There's a lot of controversies as well. When you talk about people talking about nutritional health, this nutritional medicine and all this, they always advocate a higher dose of vitamin D. But if you follow the FDA requirements, okay, the upper limit is generally between 2 to 4,000 international units. All right. So it's 4,000 international units. For you to know how much of vitamin D to take, you can actually go to your GP or your doctor or a lab or something to check your 25 hydroxy vitamin D levels. When you know what is your lack, then you can supplement with the required doses. All right. Yeah.
Sure. Thank you, Dr. Jeffrey. We know that what is osteoporosis and how we can prevent it. And so if we do get osteoporosis, or we are diagnosed with osteoporosis, then, what is the risk what are the risks of having osteoporosis? Or one risk I know it is, we can have fractures because of osteoporosis.
Yeah.
But you are the expert. How can you explain someone, what are
Okay.
the risks of having osteoporosis?
All right. So, okay. So basically, osteoporosis, because your bone becomes softer, so it's easier for you to develop a fracture, to have a fracture. So, in the elderly population, okay, earlier we talked a bit about prevention. Something which I forgot to mention was in the elderly population, you have to take very, some very important precautions to prevent falls. So, walking on uneven ground, improper footwear, footwear with rubber soles are important so that you don't slip and fall, precautions to have holding bars when you're walking somewhere and all that. This is important because number one, we want to prevent the fall. Because in an osteoporotic patient, a trivial fall may lead to fracture, as simple as falling off the bed or just slipping and falling in your bathroom. You can fracture your hip. So the commonest areas to fracture for an osteoporotic patient is three main areas. One is the hip. We call it the neck or femur fractures, the hip. Number two, the spine. Okay, you can have spine fractures when you have, these are all fragility fractures. So fragile bones, easy to fracture. Number three, you can fracture your wrist. Just a simple fall. You try to break the fall with your wrist, with your hands, and you can fracture your wrist. So these are the common things which can happen. Just with trivial trauma, not a high mechanism, high
Dr.
impact,
Jeffrey, you're
just a low impact
okay.
injury lead to fracture. You have fracture. The issue is for an elderly. Yeah. Can you hear me?
Yes, I can now.
Can you hear me?
Yes, I can.
Yeah, sorry. Yeah. Okay. For the elderly, when they have fractures, especially in the hip or the spine, they cannot walk. And when you are left immobilized because you are not able to walk, and then it opens up the Pandora's box. So what happens is all the complications start happening because of being bedbound. You may develop bed sores, you may develop, because of prolonged immobilization, you may develop pneumonia, lungs, they may develop pneumonia, and all sorts of other problems. So our aim is, when they develop a fracture, is to get them up and about walking as soon as possible. That is where we come in and do the hip replacement and stuff. Yeah.
Thank you, Dr. Free, because I think it's,
Yeah.
it's, of course, it's something it's becoming more and more common. So it's very good for
Right.
everyone to
Yeah.
know what are the risks of having it.
Mhm.
So, like when we have osteoporosis, of course, we have to have tests and,
Yes.
loads of tests, I guess. So what
Right.
are the tests done? Because at least in the UK, I can talk about it. What happens is we go to our general practitioner, or GP, we call them, and we
Yep.
go, and then, of course, we present the symptoms, then they send
Right.
for the test. Because most of the times, unless until you're from medical background or you know someone in the medical background, people are not
Yep.
very aware of what tests have to be done and what they have to
Right.
focus on. So what
Yep.
would you recommend people to look at?
If generally, if you're postmenopausal or you're older or you have high risk for developing osteoporosis, you may be on steroids due to other medical problems like rheumatoid arthritis or some other inflammatory bowel disease. You may be on steroids. You may be postmenopausal, or even in a younger age group who had their hysterectomy or ovaries removed. These are all predisposed to early osteoporosis because of early menopause. So when you have all these things and you have the risk, so to actually diagnose osteoporosis, we do something called, commonly people know it as bone scan, but it's basically a bone mineral densitometry. It's called a BMD scan, because generally speaking, bone scan, when you do a nuclear bone scan, that is a different kind of scan, but it's a general term when you say bone scan. So when we call BMD, bone mineral densitometry, that is which gives you the density of your bone. So generally, when you do a bone mineral density test, they will come out with a report saying that your T score and your Z score. That is mainly the report. So they check the density in 3 main areas, which is your wrist, which is your spine, and in your hip. So when you get a report of a T-score minus 2.5, that means your bone density is 2.5 standard deviations away from a healthy 30-year-old individual's bone. So that's what it means. So that means once you get a lesser value than minus 2.5, you are diagnosed as osteoporosis. Okay. So the other tests which are done generally are serum calcium. You can do your vitamin D levels as well. It's specifically it's 25 hydroxy vitamin D, but your GP will know that. How do you assess for your vitamin D? So if you have deficiencies in any of this, then we need to reassess your diet and see whether you're getting enough calcium, vitamin D, and supplement if necessary. All right. And then, of course, once you develop osteoporosis, then there is a whole set of other treatments which are there to actually increase your bone density. These are anti-osteoporotic medications.
Sure.
Yeah.
Okay. It was interesting to hear about the density scan.
Yes.
So why is density important then?
Okay. So the density is the one, when your bone density is adequate, that will protect your bone. So basically, it will prevent fractures. So we want to check the chances of you developing fracture. So when you're diagnosed with osteoporosis, that means your bone density is lower than the age-matched population. So this bone scan, how do they get the values? Because they did a huge study in the world, probably in UK and in Europe and all that, and they come up with the plot of the graph and they say this is the general value. So from that they measure the average, so the standard deviation. So another thing is, if you go to Google and you just type FRAC score, it's called fracture risk assessment scoring. Okay, FRAC score. So anybody can access that. It's open access. It's called fracture risk assessment scoring. So with your BMD, with your bone mineral densitometry, which you get it done with your GP or your practicing doctor, so you can actually enter your values there, your age, your height, your BMD test, and some of the values which they request there, and it will actually give you a value or tell you your risk of you developing a fracture or what are your risks. So this is available freely online actually. It's called the FRAX score, FRAX. Density is important, yeah.
Sure. Thank you so much, Dr. Jeffrey.
Yeah.
You mentioned that these averages are taken in countries like US, UK, Canada, wherever. So what happens to the population which comes from South Asia, really?
Actually, there are Southeast Asian data as well. All right. So, like say if you're in Malaysia, so in the FRAX score, when you go and enter your details, you choose the closest country to you. So Malaysia is not in the list, but Singapore is there. So our population, Malay, Chinese, Indian, multi-ethnic, the population is similar to Singapore. Okay, we are just across the border. So we can choose Singapore, and that will give you the closest match. So there are studies a lot which has been done in Southeast Asia as well. And they found that the Chinese population has the higher risk of osteoporosis and developing fragility fractures, as what I mentioned, the hip, knee, and the spine. So the Chinese population generally has a higher. But if you look at the whole world, the Caucasian population has a higher osteoporosis risk. But interestingly, the low BMI, that means you all know what is body mass index, right? Height and weight. So that means the thinner, slender individuals have a higher risk of developing osteoporosis as compared to overweight or obese, this thing. So yeah. So
at least I have something to celebrate, I was about to say.
Yeah. Interestingly, yeah. Right. Yes.
Thank you, Dr. Jeffrey. I didn't mean to interrupt you.
No problem.
Okay, so now we know what tests we can do. What are the treatments available for osteoporosis? So any treatment, I guess it is from, no treatment, or holistic approach is definitely becoming more and more common, rightly so. But of course, sometimes you do need medications or something else. So as an expert, what would you say? What are the treatments available for osteoporosis?
Okay, so of course, going back to basics, number one is diet, right? High calcium, high vitamin D diet, right? But then again, too much calcium also is not good, okay? Too much calcium can lead to renal stones, okay? So having said that, so you can check your calcium levels, vitamin D, like I mentioned earlier. Of course, first foods rich in calcium and vitamin D, as I mentioned earlier, dairy products, milks, even soya, right? Soy, and cheese and all that. And of course, salmon, fish is good. So number one, diet. Number two, when you develop a fracture, of course, you need a surgery, or if you, especially if you fracture your hip, you need a surgery for you to walk back again and load your bones. So then only you are mobile and you develop less risk. But if you fracture your wrist or your spine, probably you can be treated conservatively. Okay, as far as medications are concerned, even in our patients who develop a hip fracture, we always start anti-osteoporotic medication. So what kind of anti-osteoporotic medications are there? Maybe some of you may be on it, or maybe you know somebody who are probably taking it. One of the examples are alendronate. Alendronate is known as Fosamax, but it's known as Fosamax in Malaysia. I'm not sure what is the exact name in UK, but it is basically the chemical name. The drug name is alendronate. Sometimes it's marketed by different names, okay? So alendronate, Fosamax increases your bone mineral density or increases your bone mass by preventing the resorption, okay? So it prevents the bone from becoming soft. It kind of builds up the bone. And then there are a whole lot of other medications like teriparatide, which people know it as Forteo, and all those kind of things. Number two, calcium and vitamin D. So calcium, on top of your diet, you have to be taking about maybe 700 to 1000 to 200 milligram of calcium per day. So a tablet of calcium, you have calcium lactate, calcium carbonate. So a tablet probably is about 300 milligrams. So you probably be taking about 2 tablets twice a day. And another thing is vitamin D, of course. So vitamin D available in calcitriol and rocaltriol. Many people, once they reach a certain age, will be put on these supplements, right? Yeah, so these are the main medications. Yeah.
Sure. Thank you, Dr. Shri. As you know, I can see this is a very popular topic because I have started getting questions already from the audience or participants. So it's always a good thing.
It's a good thing when you have questions. That means everyone is listening.
Yeah, they've been put to the test.
Right.
So, okay, so I know, like in osteoporosis, we have established that people are, the tendency to have fractures is increased. Yep. So how can they prevent these fractures or falls due to osteoporosis? What kind of precautions they can really take?
Okay, so basically, fall prevention is very important for the elderly especially. So prevention of falls, number one, you should make sure your eyesight is good, because when you cannot see uneven ground and all that, then of course tendency for you to fall is very high, right? So proper footwear, uneven ground, walking, regular exercise, this all prevents. So exercise wise, low impact and low impact aerobic exercises are good. So you actually strengthen your bone and prevent these fractures from trivial falls. So falls prevention is number one. Number two, diet, as I mentioned earlier. And number three, also supplements, of course, to maintain your optimum calcium, vitamin D level so that your bone is not brittle enough to break, right? So I think for the elderly population, falls prevention. I think number four, when you're taking certain drugs like steroids, even certain patients with fits, epilepsies and all that, certain drugs can predispose to osteoporosis, secondary osteoporosis. So you need to make sure that if you're on those drugs, you need to mention to your GP or your doctor whether you may need medication to prevent the osteoporosis. So you may need supplements to further prevent. And then, of course, patients who have females post-menopausal or even early menopause due to, for some reason, your uterus or your ovaries need to be removed, then you may need to consider hormone replacement therapy. So hormone replacement therapy is not only for post-menopausal syndrome, it's also has an effect on preventing osteoporosis. Yeah.
Yes, thank you so much, because we did
Yeah,
have a gynecologist come and speak about menopause, and
right,
she
right.
couldn't tell that enough. I think I'm really glad and
Yeah,
thankful for you to be, reiterating that point is really,
yes,
really important for people, women who are
yeah,
perimenopausal or menopausal to,
yeah.
do that.
Hmm.
Thank you so much. Of course, we can prevent as much as we can prevent. And of course, we have to manage osteoporosis as much as we can, as you have said.
Yeah,
But I
yeah.
guess your role comes in when, of course, some of these things
Hmm.
haven't gone right for whatever reason. These things haven't gone according to plan,
Right.
and they have landed up with you to fix them,
Yeah.
right? So, what do
Yes.
you do? How do you
Right.
manage them then? If they have had the fractures, then what are the options they have, and what kind of people come to you, and what happens really?
Okay. So usually, generally, it's quite common for us to get elderlies with hip fractures, especially. Okay, hip, spine, and wrist. But being an arthroplasty surgeon, I always deal with the hip fractures, right? Commonly. So we in Kuala Lumpur General Hospital, we probably get about 150 hip fractures a year, right? In elderly osteoporotic fractures. So this is a high volume. So okay, so basically when they come in, they are unable to walk and they have severe hip pain. And then when we get the X-ray done, we can see that their bone density, the bone is really very porotic, which is, you can see it's very porotic, and there's a fracture. So when there's a fracture, generally we need to, our aim is to fix the fracture as fast as possible, to make them to replace the hip basically. So there are two options. Usually we do a partial hip replacement or a total hip replacement, okay, for these patients. Our aim is to get them up and walking the next day if possible. But some patients, of course, elderly patients, they have a lot of medical problems, heart problems, diabetes, hypertension, so they need to be stabilized. They need to be optimized before they can go for anesthesia and undergo surgery. So we have actually in Malaysia, or most countries actually, even in the UK or European countries and in US, they already established this long back. But in Malaysia, over the last couple of years, we have this, we call it a multidisciplinary approach just for this kind of patients, for geriatric population who come in with hip fractures. We have a combination of consultants looking after them. They are part of the the geriatricians, okay, who take care of elderly people, the anesthetists, and the orthopedic surgeons, and together with the physiotherapists as well. So as soon as the patient comes, they are seen by the anesthetists, and we aim to actually fix their fractures or replace their hip within 24 to 48 hours. That is our aim. So within 24 to 48 hours, we want to get them up and walking. Okay. So it's unlike any other fracture whereby we put a plate or a screw or some kind of nail or some kind of implant where young patients are advised to not weight bear. You have to use the walking frame, or do not apply weight on your bone. But in elderly, we want them to immediately weight bear. They want them to immediately walk. Of course, they'll be using a walking frame or a walking stick, but our aim is to mobilize them as soon as possible before they develop sores over the back, before they develop pneumonia or lung infections and all that. Yeah. So this is what we do.
Okay, so I know you have had immense, experience in this field. Can you tell what
Yeah.
has been your experience, and how you, managed these patients, one or two of them, how, different outcomes, or how did they come in, and what happened really?
Okay, so okay, maybe I can just tell you about one of the cases which I had. Yeah, so I had an 80-year-old lady who was in the nursing home. Okay, she just had a slight, just a very trivial fall from the bed actually. All right, so she had a fall from the bed, and she had to be carried after that, and she was brought to the hospital. And then she was 80 years old. Of course, she had some heart issues. She was on blood thinners, and she was having diabetes, hypertension. And so yeah, we referred her to the anesthetist, and we stabilized her. So usually, even if the patient is on blood thinners, we stop it for a few days and we proceed with surgery. So She was a really very frail lady, and we went on to do a total hip replacement for her. She was previously walking, so she was not using any form of aids. She was not using the wheelchair or a walking stick at the nursing home, but she was able to walk. And so generally we look at the functional ability before we operate. Certain patients who are already bedbound, we are not going to operate and try to make you walk, but if you are active and you are a community ambulator or even a home ambulator, our aim is to get you to walk as soon as possible. So for this lady, we went on to do a total hip replacement. Post-operatively, she was observed in the ICU for about 2 days, but after that she came to the normal ward, and we commenced our rehab and physiotherapy program, and she was discharged about 6 days post-op. Yeah, so she was already walking day 2. After out of the ICU, we made her walk with the walking frame, the four-legged walking frame, and so she had a good nursing home which had visiting physiotherapists and stuff. So we discharged her on day 6. So she's further taken away from all the risks of infection and the bugs in the hospital. So we want to get them out as soon as possible. So yeah, so she came back to see me at about 6 weeks post-op. She was doing really well. In fact, she stopped using her walking frame. She's 80. She stopped using her walking frame after 2 months, so which is really good. Yeah, so, and of course, we put her on osteoporotic medication after the anti-osteoporotic medication. She was on Fosamax to increase the bone density, and also she's been educated with regards to falls prevention. And we reiterate that to the to the nursing home as well, her caregivers. Yeah.
I mean, I think, thank you so much for mentioning that, because that's what happens, isn't it? The missing link between the different providers or healthcare professionals is sometimes a problem.
Yeah.
So in my experience, I just wanted to ask you first, and then I'll tell my example, because of course, it is great that we all have to know, but sometimes we don't. Of course, we have a fragment of a population, we are not aware of it. So for family and friends, and for them to know, what can they look out for? Like, for example, so what happened in my case is quite a few years back, when I was working full-time as a dentist. One of the patients I regularly see, and the whole entire family I see them. So she brought this her son to me and said she has gone to the TP, but he feels very tired and he can't even walk from her home to the school, and he's always tired, he's not doing well. And of course, I just looked at the teeth. That was my forte. So I looked at the teeth, and we fix whatever we have to fix there. And then I just mentioned to her, have you checked his blood test, and maybe did you check the vitamin D or whatever? Few weeks later, that mom specially came back to tell me that the vitamin D was low. And that is what's happening. But obviously, I guess I was lucky, or they were lucky, that that thought came to my mind, and I just mentioned. But so, as family and friends, is there anything people can spot these things for?
Yeah. So, okay, you were mentioning about a young boy, right?
Yes, correct.
Okay, vitamin D deficiency in the young will lead to rickets. You all have heard of rickets, right? So vitamin D deficiency in the young leads to rickets. So we don't really see rickets nowadays. We all mostly in developing countries, but in the very low socioeconomic status of patients, I think India still probably has, and of course South Africa and all have a lot of rickets. So there are actually deformities which you can spot when you have rickets. There will be a lot of bony prominences, and they can have bowing of the leg, deformities, basically deformities. If your legs look deformed, you have to screen for rickets, right? So basically they check the vitamin D. For elderly, if you have osteoporosis or you have never checked your bone scan or what, usually you may be having axial pain. Axial pain means back pain, like back pain, central pain. If you have non-specific back pain, not because you carried something heavy or your wrong posture, but suddenly just out of the blue some very vague back pain, and then hip pain, bony pains are suggestive of osteoporosis. Okay, so it not necessary. I don't mean to say that all bony pains are osteoporosis, but if you having this kind of things, and or maybe prominent some kind of bone protrusions here and there, you know, it can be arthritis as well, but you have to screen for all this. So in those sense, you can screen for your vitamin D, calcium levels, phosphate levels, and also check your bone mass, bone mineral density. But generally, in most, if you're going for a regular regular checkup, medical checkup, most people go for regular medical checkup 6 monthly, 1 year once, especially once the age of 40 above or what, you know, just to screen for everything. Most hospitals do offer bone mineral density as part of the routine. All right, so that can give you a indication as well. But generally, it's bone pains and these kind of things. When you have a previous fragility fracture, the chances of you having osteoporosis and needing anti-osteoporotic medication is always higher. Yeah.
Sure. Thank you so much. This particular patient didn't have rickets for sure. So it's just the tiredness and the mother saying the kid not being able to walk a short distance to school. That's what kind of made me think. I just got lucky, as I said. I had, you know, I just thought, you know, it's worth getting the basics covered, and I guess so that's the reason I asked you, because I think very often, or at least sometimes, people don't know these things, and you know, we don't put these things together. And I think and bone density test, there are quite a few doctors listening, so I'm sure they will say, have something to say afterwards. But all I can say is I have never been offered, and I have definitely well past the age what you said. So yes, but I have never been offered, so it'll be interesting to see what other people really think about it. So okay, so going back to the basics now, we spoke about what is osteoporosis and how we can diagnose, how we can prevent them, how we can manage them. If you have to tell 5 things, 6 things for our audience must remember to take home, what would they be?
Okay, so I think maintaining a balanced diet, which is adequate in all the necessary supplements, is very important. So we have to for bone health, adequate calcium and vitamin D rich diet, okay, with adequate protein for your muscles, you know, because muscles are important. Muscle function protects your bone. So muscles are around the bone. So if your muscles are healthy, then your bone is also healthy. So protein, adequate calcium, vitamin D, right? Supplement if necessary. When you check your calcium levels, phosphorus levels, vitamin D. Vitamin D levels are not commonly checked, but if we are aware of it, when we check, then we know we need to supplement. All right. So, and then of course, daily exercise, or even 3 to 4 times a day, 3 to 4 times a week. Sorry. So roughly about 30 minutes of walking, low impact aerobic exercises are important to maintain your bone and muscle function. So if you're active, then your bone remains healthy. And of course, falls prevention for the elderly, precautions, falls prevention. And last but not least, generally just striking a balance. Okay. One more thing which I forgot to mention about risks. Even alcohol and smoking is also a risk factor for osteoporosis. Okay, so of course, avoiding smoking. Alcohol, generally the UK recommendations is less than 2 units per day drink. Anything more than 3 units per day can predispose to osteoporosis, right? So maintaining a balanced lifestyle is utmost important. Then the last but not least, medications and supplements come into play, right? Yeah.
Sure. Thank you so much. I mean, now you have put the spanner in the work. I wasn't planning to ask any more questions in this, but you said about alcohol. I was like, you know, I'm sure a lot of people will be wondering why not.
Right.
What is the connection between osteoporosis and alcohol?
No, alcohol predisposes. There's no clear direct pathophysiology why alcohol kind of this thing, but alcohol has some effects on the bone mineral density, because usually the bone, it is a balance between the bone forming cells, which are the osteoblasts, and the bone resorpting, because as old bone cells die, the new bones need to lay, so it has an effect in this balance, so it causes the bones to become more brittle. Prolonged alcohol intake, high volume alcohol intake, right? Yeah.
I'm sure a lot of people are listening to it carefully, particularly when another couple of months Christmas will be around, and we will definitely have to think about this.
Yeah.
Thank you so much, Dr. Jeffrey. It has been very, very informative. We have had lots of questions, so it's going to come your way very soon.
Okay, sure.
But following tradition, I'm going to start announcing the next week's speaker and then go from there. So for next week, we are going to be speaking about respiratory care. That would be our 57th episode. It is from Prof. Raj K. Rajakulasingham. Diagnostic challenges and management of bronchial asthma would be the focus. He has an MBBS, MD, FRCP, and FACP. He's a consultant physician in respiratory medicine and allergy at Umberton University Hospital, London. Honorary clinical professor in medical education at QMUL, principal internal examiner and cardiorespiratory module lead for year 3 medical undergraduates, and QMUL examiner for PACES RCP, author of several peer-reviewed publications since 1993. And the list goes on. He has done a lot. And I have asthma myself. And I know a lot of people who have asthma, so I have a keen interest to see what he has to say as well. So I can't wait for him to come for the next time. For this time, we are not over again. So thank you so much, Dr. Jeffrey. Over to Kirbe Kohut to give the vote of thanks.
It's, after a week of having a break, I've been having withdrawal symptoms. We missed all of you on Facebook last week. We took a break. We thank you for your ardent support coming on Facebook to listen to us on Meet Menaca, celebrating you, and all those participants who are faithfully attending our platform. We welcome you, and once again, thank you for your support. Last and not least, I'd like to thank the speaker who I've known all my life, and that's Dr. Jeffrey Jairaj. And my signature is always to do an acronym with the name, which is Jeffrey, but I'm going to do it Jeff for short, because Jeffrey is a bit too long, okay? Jeff, this is what I always sense in my heart about you, and we are really happy that you have graced this occasion. J stands for someone who's always jovial and makes things very light and possible. E stands for being very empathetic. I'm sure that you make your patients very accommodative, and you always see a positive and help them understand. F stands for fun-loving, always making a joke out of everything. And F finally stands for a fantastic doctor. And being your cousin, I am really proud of you, Jeff. Thank you once again, and glad that you could make it on Meet Menaca, celebrating you. Thank you.
Thank you. Thank you.
Thank you, Kirby. Thank you, Dr. Jeff. And I must admit, you got very short notice from us. And thank you so much. And as exactly like Kirby said, you're so easy to talk to. And when I reached out to you, it was a conversation flowing as if we knew each other for a long, long time. So thank you so much for being so easy and accommodating us and enlightening us with many informations as well. So there are a lot of questions from the participants, and some of the questions came through emails for me before the session. I am going to go through a few questions as much as I can when I'm on live. But even after we come off the Facebook, we will continue to take the questions from the participants. The first question to you is, the MRI was done on the 18th of July, 2021. Observation, the established lumbar spondylosis with degenerative scoliosis, multi-level disc disease, and florid facet joint changes are stable with respect to imaging from May 2021. Conclusion. So notable for lumbar spondylosis with severe facet joint changes and possible radicular compression. I have only a slight pain at the back when I get up from the chair or when I walk. What should I do to prevent further deterioration? That is your first question. I'm so sorry. I'm sure it is a doctor who asked the question. So it's packed with medical information.
No problem. No problem. I mean, this is something very common actually. Okay, but disclaimer is this is not necessarily due to osteoporosis. So this is also a degenerative condition. But similar to how you get arthritis in the knee or hip, when your cartilage gets thinned out and all that, and then you start having pain in the joints, similar to that in the spine, there are also small little joints just articulating the spine, the backbone articulates with each other. Those are called the facet joints, all right? So the facet joints also can have arthritis. So these are degenerative conditions, and lumbar spondylosis with scoliosis and as you mentioned in the MRI, it's a degenerative condition. Radiculopathy means the nerve occasionally gets compressed. Okay, if your back pain symptoms and your numbness or the weakness or anything which you're having is not so severe and the pain is manageable, I would still recommend conservative treatment first. What do I mean by conservative? Of course, physiotherapy, medications, anti-inflammatories to reduce your pain, and basically continue doing your exercises, low impact, and continue with your physiotherapy to strengthen your back muscles. And always for spine problems, even though I'm an orthopedic surgeon, I would say, maybe some people may not agree with me, but surgery is always the last option. When it comes to spine, surgery is always the last option, okay? If you tell me your knee or hip is hurting really bad and bad arthritis, I would not say the same thing. But when it comes to the spine, surgery, always keep it as a last option. Judging from the question, the symptoms are not that severe. Occasionally, some pain and some numbness, which can be managed by medications. There are nerve medications which you can take, B-complex, neurobion, even certain nerve-related medications for neuropathic pain like Neurontin or gabapentin or Lyrica. Those kind of medications your GP or your orthopedic doctor can prescribe. Okay, and physiotherapy regularly and correct posture is very important. When you have to sleep, you sleep in a firm mattress. Do not bend at your hip or your back to pick up something from the floor. Always bend at your knees. And next thing, don't carry anything too heavy because you may sprain your back and aggravate the condition. So as far as if you can manage all these things, you can actually live with these minor degenerative conditions. When the nerve is permanently compressed, then you need some form of relief. You need some form of decompression. So then you go on to slightly invasive more methods, not a major back surgery, but you can try injections, steroid injections or nerve relieving compression injections to the back to relieve your nerve compression. So this one are done by interventional radiologists or even certain orthopedic surgeons. So do all this first before you actually decide or resort to any form of surgery. That will be my advice. Yeah.
Sure. Thank you so much. It's a very comprehensive answer. So thank you.
Yeah.
So the next question to you is, I think, what is the frequency of getting a bone density test? I think you mentioned every 6 months.
So generally, you don't need to do it every 6 months actually. Okay. Generally, a yearly once is okay, but you don't need to also you routinely do it. If your bone density comes back as you're just, sometimes it just reports as osteopenia. Osteopenia means there is reduced, but it's not at the level of osteoporosis. like I told you, below minus 2.5 T-score is osteoporosis, established osteoporosis. Okay, but that means your bone density is 2.5 standard deviations below the age matched population. But if it's between minus 1 to minus 2.5, you are probably osteopenic. That means you have lower bone density, but you are not osteoporotic yet. In that sense, when you improve your diet and you exercise and all that, you are maintaining your bone, this thing, you do not have to repeat a test. But if you are on medication, if you already established osteoporosis and they start you on anti-osteoporotic medication, probably will repeat a bone scan in 6 months to 1 year to see whether the T-score is improved and the medications has worked. Because we are trying to reduce the risk of you developing a fracture. That is the important thing. Yeah.
Sure. Thank you so much. The next question which has come through is, does HRT helps or prevent osteoporosis?
Hormone replacement therapy for postmenopausal, there are many types of hormone replacement therapy, but the ones which contain estrogen and progesterone, of course, helps in maintaining bone health. But to say definitely 100% is going to prevent osteoporosis, it is not so. Okay, so sometimes of course it falls back to bone mineral density and also the FREC score. If your bone mineral density is lower, then you may need other medications to supplement to the HRT, right? So HRT is not the first line for osteoporosis. We don't regularly give HRT just for a diagnosis of osteoporosis. But if you have very strong symptoms of postmenopausal syndrome, very strong symptoms where the gynecologist feels that you require HRT, then we will also check your BMD, your bone mineral density, and see if you require any supplementation for your to prevent your fractures and treat your osteoporosis. Yeah.
Sure. Thank you so much.
Yeah. Right.
The next question which has come through is, what are the best exercises to do to prevent osteoporosis?
Low impact, basically low impact. I would advise against jogging, but walking, brisk walking is very good. Brisk walking, even if you are not able to walk very brisk walking, even normal walking, even on a treadmill. Treadmill is, they call it elliptical cyclical exercise also is one way, or even on a treadmill. Treadmill level, you walk not too high speed is fine. Okay, elliptical cyclic exercises are like stationary bicycles and all you can do also. Okay, that is good. Walking, brisk walking, do not jog, because jogging, the load which your knee and your hip needs to take is very high. When you jog or you run, it is 5 times the amount of your body weight, so you don't want that. All right, so walking is fine. Tai Chi is good. Some people do Tai Chi, especially the Chinese community. Even yoga is good, but yoga, you can go to the extremes. Some maneuvers in the yoga is very extreme. So maybe you can do within your means. What you can, this thing. Do not push beyond what you can manage. Do it within your ability. So because you don't have to overdo, but you do it how much you can tolerate. So basically low impact, and like aerobic exercises and all that is fine, right? Swimming is good. Yeah.
There is a this is perhaps the last question while I am on live I'm going to take, is what is your recommendation as a source of calcium for those who are vegetarian? Can eating vegetables provide daily requirement of calcium? Because I think it's an important question, so I just squeeze that in before we come off live.
Yeah. Okay. Vegetarians, from some of my reading, of course, there are reports to say that vegetarians have lower vitamin D, lower calcium, and all that. But I mean, there are a lot of sources of vegetarian sources of calcium, phosphorus, and vitamin D. Example, kale. Kale is good. Kale. Even bayam is spinach, broccoli, and soy-based stuff. Vegetarians can take, right? Soya, tofu, those kind of things. Yeah, soy-based is good. If you are a vegetarian who takes, maybe if you're a pure vegetarian, you don't take eggs, so then that is off this thing. But All dairy products, milk, cheese, yogurt, all these are rich in those kind of what you need basically. Yeah.
So
But actually,
vegetarians,
if you just Google, you'll get a whole bunch of yeah,
Google is our friend.
right. Yes, yeah, Google is our friend. Yeah, yeah. These are some of the ones which I remember. Yeah.
Okay, thank you so much, Jeffrey. It's like it's a pleasure having you as a speaker here. But of course, we are going to continue this. So people who are on the Zoom, please stay back because we are going to continue with the questions. I have many more questions which are waiting to be asked. However,
Okay.
for people who are on the Facebook, thank you so much for joining us. It's always a pleasure to have you joining us. Of course, we always share these links. So please do join us on the Zoom if you want to, because you get a longer time and also you get a chance to ask the question directly to the speaker if you're on the Zoom. And as ever, thank you for supporting us. Please subscribe to our channel and support us so that we can spread this message far and wide to everyone who needs it, because as you know that we cover from health to social issues to different things. So the more you support us, the more we will be able to support everyone around us. So thank you so much. Next week, we would be speaking about respiratory care with Professor Rajakulasingham. And I think his focus is on asthma. So I'm sure we will be speaking a lot of about asthma and allergic reaction. It's becoming a commonplace for us for sure. So until next week, it's time to say goodbye. Until we see you again, stay safe, be happy, and keep smiling.